Hello, everyone, and welcome to our second session of the Acute Syndrome Foundation's Family and Researcher Roundtable. As you may know, my name is Craig. I am the Executive Director, and I am mom to Stella, my fierce SNAA warrior that just turned 10 last week. Like many of our kids, Stella has a variety of seizures and lots of different types that often leave me wondering how to describe them to her neurologist or how to document those episodes. When I asked for expert guidance on seizure classification, Dr. Michael Hammer replied immediately, and I quote, Dan Lowenstein at UCSF is the master. So that's who I contacted, and that's who we have today. So without further ado, it is my honor to introduce Dr. Daniel Lowenstein, Distinguished Professor of Neurology Education and former Executive Vice Chancellor and Provost at UCSF.
Great. Casey, thank you so much and welcome everyone. Can you hear me okay? Thumbs up. Chloe, I see
Yes,
you. I see you. Yes? Okay.
we're good.
Great. Well, yes, I really appreciate the opportunity to have this conversation with all of you. And Casey and I have been going back and forth a little bit over the last few weeks as to what the best way is that I might be able to be of help to all of you. And we decided that, yes, we are going to dive into seizure classification. But in order to do so, I just want to make sure that everyone's on the same page regarding exactly what seizures and epilepsy are all about. And I imagine that some of you are completely knowledgeable about this, but I'm also imagining that at least one of you may not have a complete sense of um, what's going on in a person's brain when they're having a seizure. And I can't really get into the topic of seizure classification without thinking about that more fundamental understanding. So that's the plan. I'm going to share my slides, and you should see a red star. At the moment, I can't see the rest of you. So Casey, you're going to have to chime in, or anyone can just speak up if you're having any problems seeing my slides.
Sounds
Uh,
good.
Okay, everything's good. Okay, so here we go. We're going to start off with, and let me see if I can advance properly as well. Let me try one more thing here. I'm going to stop the share for a second and try a slightly different approach and share this one. Make sure that it advances. Okay, this one's advancing. Okay. All right. So, what we're talking about here, of course, everyone knows, is the amazing human brain. Pictured here. A somewhat appropriate image given that Halloween's coming up in a couple days, seeing the skull. But the human brain is arguably the most remarkable entity in the known universe, and it is as complicated as can be. It's probably, I tell our medical students, it's probably the most complicated organ they'll ever see. And in order to think about seizure classification and seizures, I just want to make sure that we all have an understanding of the most basic aspects of the human nervous system. So again, pardon me for anyone who knows this stuff inside and out, but just to make sure, let's start with some basic anatomy. Okay, so first of all, the human nervous system has two components: the central nervous system, which is made up of the brain and the spinal cord and the nerves that come out to our face, um, or actually the brain stem itself, and then the peripheral nervous system, which are the nerves outside of our brain and brainstem and spinal cord that innervate our muscles and bring in information from the outside world. So there's both the motor movement that starts from the brain and goes out to the muscles. And then there's the sensation that we're able to have on our skin and in our joints that brings information in to the brain. Vision would be another example of a sense that comes from the outside in. So peripheral nervous system, central nervous system. Epilepsy is all about the central nervous system. And within the central nervous system, there are three major components. One is the cerebrum, which is the thinking, the doing, the sort of the most eloquent, complicated part of the brain. There's the cerebellum, which sits in the back, which helps with coordination of our motor movements and other things, but not typically involved in seizures. And then there's the brain stem, which is the connection between the cerebrum and the spinal cord and has a lot of very vital functions, including things like allowing our eyes to move, feeling sensation on our face, and also controlling respiration and heart rate. So I'm sure you're all familiar with sudden unexpected death in epilepsy, or SUDEP, which is something that frightens us all and that we want to try to prevent on all costs. And it's the brainstem that may be getting involved in some seizures that cause changes in respiration and cardiac function that could be the basis of SUDEP. But these are the three main areas. And then, you've all had the opportunity, I imagine, to look at CT and MRI scans as part of the evaluation of the loved one in your family with epilepsy. And I just want to make sure again that we're on the same page when you're looking at these images. As you can see, when we do a CT scan or an MRI scan, we can look at the brain in multiple different axes. The three main ones are the horizontal plane, shown on the left, the coronal plane, which is sort of cutting through from top to bottom, sort of like the corona, Jesus's corona. And then there's the sagittal plane, which goes through the sort of the midline. And the MRI images that you're seeing below correlate with what I've shown in the top panel. So this is looking at a person's brain in the horizontal way. The front's here, the back's here, front, back. This is in the coronal plane, and this is one side versus the other. And in fact, in this case, we're seeing the cerebrum as well as the cerebellum, that part that I said was sort of in the back and the lower part of the brain. And finally, this is a sagittal section, in this case going right through the middle. And you can see, by the way, can you see my arrow? Yep. Okay. So I'm pointing out the cerebrum. Here's the cerebellum. And what is this? That's the brainstem connecting the cerebrum down to the spinal cord down here. Okay? Everyone oriented? Cool. Okay. All right. Now this one's really important for classification. So pay attention. This is a sort of another view of the cerebrum. And I'm going to point out the different lobes of the brain. Again, recognizing that many or all of you may already know this stuff really well, but I just want to make sure. This, of course, is the frontal lobe. And the frontal lobe is important for those higher complex functions that we have that we're capable of, like executive functions, like planning, uh, like doing calculations, uh, all the higher order sort of emotional processing, all the higher order thoughts that we have are based on the frontal lobe. In the very back part of the frontal lobe, however, is what is the motor cortex. I'm outlining it right here. So even though it's in the frontal lobe, it doesn't have that thinking property that this part of the lobe does, but it is the vital place where we're able to move our body. So if you want to move your right arm, your frontal lobe may say, "Hey, I want to move my right arm." You send a signal here to the frontal lobe, to the back, this motor strip, and it gives a command to move your arm on the opposite side. The right side of the brain is interested in the left side of the world. The left side of the brain is interested in the right. So that's what the frontal lobe does. The next one is the temporal lobe. Very, very important with regard to epilepsy because it's a common location of seizures. And the temporal lobe is responsible for language, especially on what's called the dominant side of the brain, which is typically the left side of the brain for almost all of us. So it's language, emotional components, and extremely important, memory. So sitting deep within the temporal lobe is this structure called the hippocampus. And we're all using, if you're paying attention right now to anything that I'm saying, and you're going to be trying to remember something that I said seconds ago, your hippocampus is very active right now, allowing you to lay down these memories of anything that you're seeing right now. So really important structure. So I would call it also a complicated lobe because it has things to do with memory and language. Then there's the parietal lobe, which is farther back, and the parietal lobe has to do with sensation, with being able to detect things in the outside world that I described earlier. So if you're feeling something with your fingertips, the information is being picked up by the peripheral nerves, sending it up your arm into the spinal cord, up through the brain stem, and eventually to the parietal lobe so that you can actually experience what it is that you're feeling in your fingertips. Okay, so it's sensory. And then finally, the occipital lobe. The occipital lobe is totally devoted to vision. So everything that we're seeing right now is based on the fact that light is coming into our eyeballs, hitting the retina, the back part of the eye, being sent all the way back, crossing actually, so that the left occipital lobe is seeing the right side of the world, out of both eyes, by the way, and the right occipital lobe is seeing the left side of the world. Okay, so occipital lobe is vision. As it happens, jumping ahead about classification, the occipital lobe is one of the less prone areas for seizures. Interesting, huh? Yeah. The main ones are temporal lobe and frontal lobe, although you can have a seizure anywhere in the brain, but the occipital lobe is a little bit less likely. Okay, so now let's take a look at a person having a seizure. The videos that I'm showing, there's one in this slide set, and then if you're interested and if we have time, I have a series of other videos to sort of test us on classification. All the videos I'm showing are either patients that we've cared for here at UCSF undergoing video EEG telemetry, patients who have given me permission, us permission, to be used for educational purposes, or they're videos that I've found on YouTube or online, in which case, given that it's public, I feel that it's appropriate to be able to use. Okay, so here's a patient. Okay, so obviously this is a person having a tonic-clonic seizure, and we'll talk about this a little bit further. But let me just stop here for a moment and ask the question that I was talking to Casey about before we all got together, and that is, um, and maybe Casey, you can use chat to get the response, or people can just
Mhm.
speak up. How many of you have a really, really clear understanding of what's going on inside this person's brain when they're having a seizure? I mean, we know that she's having a seizure, but do you have in your mind's eye what's happening in the brain at the neuronal level when this is occurring?
I think for me, I imagine because like the whole brain, essentially, I imagine like the storm, but I don't have it down to that of a much of a detail.
Okay. How about others? Any yes, I understand, or not sure?
Not at all.
All right. Okay. Well, regardless of what the others say, then between Casey, your response, and not at all, I'm going to dive into this
Sounds good.
because I think it's exceptionally important. So it's important in order for all of us to understand how to think about epilepsy and its classification. So in order to do that, we need to go to some fundamentals here, and that is trying to understand what what the substance of the brain actually is. And you all know this to some extent. The cell type in the brain, there are a number of ones, but the ones that are primarily responsible for seizures are neurons. Just like all of our organs have different cell types. There are skin cells, their job is to cover our body. There are liver cells, the job of liver cells is to clean out the blood. There are kidney cells to make urine. I could go on and on and on, right? The heart muscle cells to contract the heart. The real doer in the brain itself are neurons, and they're individual cells, but they're highly, highly connected to one another. And here's what a neuron looks like. This is just one of a gazillion different types of neurons. They don't all look like this, but they all mostly have this basic design. And that is there's a cell body here, which is where the nucleus is, where the DNA is. and where all the proteins are made for the rest of the cell. There's a section called the dendrite, which is the receiving end of the neuron. It's where it receives signals from another neuron. And when it sends a signal, it creates an electrical activity that travels down this section called the axon. And the axon eventually leads to what's called an axon terminal, the end of the axon, which then makes a synapse with the next neuron. Also shown here are things called Schwann cells. I'm not going to go into any detail about them, but they're like what wraps wires. It's what it insulates the axon to allow for very efficient electrical transmission. Okay, so that's a neuron. So the other thing is, neurons are signal generators. They're little electrical machines that fire off signals, but they don't work in isolation. As I've said, they work in an incredibly complex network. And the way that two cells talk to one another is if neuron 1 here receives a signal through its dendrite and decides to send the signal down its axon, it then makes a synapse, which then stimulates, or in some cases inhibits, the next neuron in the series, and that may cause the cell to fire off yet another signal. Okay? So that's the way neurons talk to one another. Here's what's particularly amazing. This is what just one tiny part of the cerebral cortex looks like. This is a stain that shows a lot of the neurons in a very, very thin section of the brain. And this is a stain that's just picking out a proportion, a small portion of these cells, just to give you a sense of the unbelievable complexity of their architecture. I mean, look at each of these cells. You've got cell bodies of different sizes. You've got dendrites here that look different. You've got these axons that in this case, many of them are going up in this direction, but this is a tiny portion of what you're seeing here. And here's what amazing, really blows my mind, is there are about this many neurons in our brain. Not only are there 10 billion neurons, sorry, 10 billion neurons, there are about 100,000 connections for each neuron. And if you do the calculation, that means there are 1 quadrillion connections in our brain right now. So last night, as I was getting ready for this, I asked ChatGPT, how does this compare to the number of grains of sand on the Earth? I was hoping it was going to be like, more than 100 planets. It isn't. It's only 1/7,000th of all the sand on Earth. Okay? But that's packed inside this one skull, by the way. So
Right.
that's crazy. Okay,
It's
so
crazy.
yeah, all right. So I think this is the last thing I want to go into with regard to individual neurons, and that is for you to have a sense of how, I mean, how does a cell, made up of, this sort of body material, proteins and fat and things like that, how does it actually make electricity? Like, it's not like a battery, is it? Well, it kind of is. And um, uh, stay with me on this. So I'm going to show you 3 slides that talk about the way a cell, a neuron, makes an electrical signal. The first is at rest, there's a certain difference between the positivity on the outside of the cell. So this is the membrane of the cell. This is just one tiny little portion of the neuron that I showed before. So this is the membrane. This is outside of the cell. This is inside of the cell. And these are ion channels. You've heard about them. You've heard about them because that's the way a lot of our medicines work. So ion channels allow these charged particles to move in or out of the cell. And they're selective. So like this one allows for both sodium and potassium. K is potassium, Na is sodium. This one only allows sodium to go in or out. This one allows only potassium to go in or out. But the key thing here is at rest, in a cell that's not firing off, just sitting there, it is relatively negative on the inside, just because of the number of proteins and things. So there's a difference in charge between the inside and the outside. So that's at rest. Now, when there's a what we call a depolarization, where the cell is going to generate an electrical signal to send down the axon, the sodium channels open up and they allow a lot of positive charge to go inside the cell. So the cell has become less negative, and that then allows for electrons to move along the inside of the cell. And that's actually how it creates electricity. And then finally, to settle back down, it repolarizes to go back to its resting state. And to do that, it sends a bunch of the sodium back out, or a bunch of the potassium back out. Okay, so that the inside of the cell becomes eventually more negative back to its resting state. Okay, so that's how neurons work. They're basically moving these charged ions back and forth. All right, so the last thing then is you send that axon, you send that electrical signal down the axon. What happens when it gets to the synapse, the meeting point between the end of the axon terminal, and the dendrites of the next cell? Well, what happens is when there is a depolarization or an electrical signal that is sensed by the axon terminal, it then does this remarkable thing. It allows these neurotransmitters that are all packaged in these little bubble-like things, it allows them to release the neurotransmitter, which then occupies a neurotransmitter receptor that then allows for a nerve impulse to be conducted to the next neuron. And the reason I want you to understand this is that a lot of our anti-seizure drugs work on these neurotransmitter receptors. Okay, so the drugs we're giving to our loved ones are working either on the ion channels that I talked about before or these neurotransmitter receptors. Okay? Okay, I think that's about as deep and complex as I'm going to get. But now you know how a neuron works. Okay, it's an electrical signal generator. Okay, now what about the EEG? So all of us know about what an EEG looks like, but how does it work? Well, you know that we put these electrodes on the surface of the scalp, and yet they're able to pick up the electrical signals that are, geez, I mean, at least half of, or three-quarters of an inch away from, where your scalp is down, because it's picking up the signals of all these neurons. We looked at a picture of some of the neurons before, and it's the electrical signaling that's taking place in large groups of neurons, thousands of them, that are hyperexcitable and then depolarizing in a similar time scale that allows for the EEG electrode to pick up the signal that you're seeing here. Okay? So that's how an EEG works. As I said, electrical activity from lots of neurons. So when you're looking at an EEG, you're not looking at one neuron firing, ever. The scalp electrode could never pick that up. It's so far away. But you're picking up like a community of neurons that are firing they're firing away, and I'll show you normal versus abnormal activity, because here's an EEG that is normal. All right. So I won't go into the details here unless you ask me questions about it later, which I'm happy to try to answer. But the EEGs are based on where those scalp electrodes are placed. And I'll just tell you, I'll tell you that in this case, we've got from front to back every four electrodes, every four traces. Okay, so this is the front. This first trace is the front. Then it goes farther back in the head, and this is in the back. All right, and uh, each four trace is along different rows going from front to back. So let me just ask you, Casey, I may be putting you on the spot, but also anyone who wants to answer, just turn on your microphone. Um, do you see anything abnormal in here? I mean, does anything stand out here?
I was going to mention, see, and I don't know if it's abnormal, but all of them are doing it. That first dip seems to be a bit longer than the other dips.
Yes, exactly. That's what I wanted you to pick up. So,
Oh, yay.
so yeah, so everything, I mean, if we didn't have these dips, as you appropriately are calling them, everything would kind of look the same, and that would be normal background activity. And um, uh, these dips are only in the frontal part, right? If you look, they're only in that first, mostly in that first trace. And that's because they are picking up the movement of our eyeballs when we blink. So it has nothing to do with the brain underneath. It's that the our eyeballs actually are electrically charged, and when we blink, our eyes, even though we can't see it because your eyes are closed, your lids are closed, your eyes actually move, and when they move, they cause this. So it's just an artifact. It has nothing to do with the regular brain activity.
I
But
had
what I
no idea that was,
no,
was
well
what
there you
the
go.
dips were. No
All
clue.
right, so good. I'm going to put this on my list of things my students have learned. Casey, yes,
There
she
you
knows
go.
about eyeball. Okay, so but the real point here, everyone, is that if you just don't look at the dips, just look at the background activity, kind of chaotic, don't you think? Yeah, that's normal because if we listen into the cells that are going on in our brain that are firing, the neurons, they're just basically doing their thing. I mean, some of them are helping me move my hands right now. Some of them are helping me speak. Some of them are helping me trying to figure out what's the next slide going to show. And that's just the normal chaotic activity of our brains. It's completely normal. Now, here's a seizure. And I think you can tell that we start with normal background activity and look what's happening. Right around here, we're starting to see the buildup of electrical activity. And now that I know that you understand how neurons are firing and how the EEG picks it up, I'm hoping you're with me when I say that the reason we're seeing this buildup of activity is a larger and larger number of neurons are firing in a higher excitable way, and they're very synchronized. That's the only way we could pick this up from a scalp electrode. And so we're seeing the onset of a seizure. I don't know exactly where the electrodes are for this particular EEG, but it's starting wherever those electrodes are. And whoa, look what happens as it starts to continue and grow. It eventually takes over other parts of the brain because it's picking up electrodes all across the scalp, right and left. Okay? So this is what the EEG shows us. Now I can tell you something I'm assuming you know, but this is the definition of a seizure. It's a paroxysmal, sudden change in cerebral function due to uncontrolled excessive discharges from a population of neurons. And what I've shown here are a whole bunch of neurons, and they are firing away in an abnormal way. And the key concept, everybody, is that a seizure is due to hyperexcitability and hypersynchronization. Okay? So now, again, in your mind's eye, when you think about a seizure, I'm hoping you can now envision those neurons, like the neuron itself, connected to one another, firing off signals, but they're firing off in a more excitable than normal way, but really important, they're hypersynchronized. Okay? It's a whole population of cells, thousands, tens of thousands of them. All right. Just to make sure we have our definitions, epilepsy is not just one seizure, it's a tendency for recurrent seizures. And here's a term that you may or may not have come across. I teach this to the medical students here. It's called epileptogenesis, and that's what turns a normal network into a hyperexcitable one. And I'm just listing here some of the causes that you're undoubtedly familiar with, especially genetic, because roughly 60% of all people with epilepsy have a genetic cause. But there are also people, as you know, who have had traumatic brain injury, a scar on the brain, or they've had an infection, and these can also be the cause of seizures and epilepsy. Okay, now we're ready for classification. There are basically two overall types of seizures. One are generalized seizures, in which the entire brain essentially is having the abnormal hyperexcitability and hypersynchronization that we just talked about. Okay, so that's one type, and we're going to go into a little more detail in a second. And the other is focal. in which there's one part of the brain that is undergoing the seizure activity, and it's not taking over or not involving the entire brain essentially all at once. All right? So that's the conceptual basis. But now let's dive in a little bit deeper because this was the topic that Casey asked me to cover. Okay, I'm going to show you literally the exact same slide that I share with our medical students here at UCSF. In fact, it just happens to be that this morning I was teaching our second year UCSF medical students about seizures and epilepsy. So this is epilepsy day for me. So this is the slide that I go over with them. And here's the way we classify seizures. As I've already said, one of the two main categories, there's actually three, but we'll get to that. One of the main categories is a focal seizure. All right? Now, let's have some fun with this. Imagine if I had a seizure generator in my hand and I could place it on my scalp and I could cause hyperexcitability and hypersynchronization in the region wherever I'm putting the seizure generator. Okay? A device like this doesn't quite exist, but we're magical thinking. All right. Imagine if I took that seizure generator and I put it right over the part of the cortex in the frontal lobe, in the back part of the frontal lobe, which is controls motor behavior. I referred to that before, right? Okay, so I'm putting it over my left part of my um, motor cortex. What do you think the seizure will be like?
See if
And
anybody
by the
else
way,
wants to jump in.
yeah, please, yeah, for people, if you don't mind, I don't need to see you, but if you want to unmute and just say something, that'd be great.
There you
Anybody.
go. Megan, right motor.
Right
So
motor,
the right side is
the
going to
right
be
side, and
movement.
it would be a motor seizure. Exactly right. And so here's how we classify that. It's focal, right? It's only in one part of the brain. We call it simple because there's no impairment of consciousness. If it's just in one small region of the brain, depending on where it is, but certainly in this case, the person will not have any interruption of their awareness of the outside world. Okay? So it's simple. And because it's purely motor, we call it a focal simple motor seizure. Okay? And the manifestation may be twitching movements or clonic movements of the hand or the face because the motor cortex includes hand and face and legs and stuff. So it depends on where it is. Now, I'm going to move the seizure generator back to the parietal lobe. Remember the parietal lobe? So what do you think the seizure will be in this case? Oh, I love these moments. I have this same experience with my medical students. They're just sitting there thinking, thinking. Some of them are afraid
Hmm.
to speak up. What do you think?
Okay, parietal. I was trying to
Parietal,
remember. Is that, no, it was the temporal was memory, right?
memory and language. Yep.
Was there
Parietal
some
was,
motor?
no, sensory.
Sensory.
Sensory. Okay. So the seizure may be just having a really unusual sensation in one's arm or leg or face. Okay. We still call it simple because there's no impairment of consciousness. It's just in the sensory area. So we call it focal, simple, sensory seizure. All right. And then there's some others. I threw in autonomic here. I teach that to medical students. You don't need to worry about that one. Okay. Now, let's change where the seizure generator is. I'm going to put it over my left temporal lobe. Left temporal lobe. What do you think might happen?
Well, it's going to be on the right, affect the right side. And we said temporal had to do with memory and you just said
Language.
it.
Language.
Language.
Yeah. Okay. So imagine yourself. Put yourself in my shoes here. I've just generated a seizure in my temporal lobe. So my temporal lobe is not going to work normally. Okay. Um, uh, be there with me. Okay. Um, what's going to happen to your memory? You're not going to be able to keep track of what's going on from moment to moment. And will you be able to speak normally? No, because language is impaired. So in that case, this is not simple. This is actually complex with impaired consciousness. Now, I didn't say
Mm.
complete loss of consciousness. I said with impaired. So that means that the person may suddenly stare off, not be able to speak, um, certainly not have any memory of the event. They're not going to interact normally with the outside world. It's still focal, though, but it's in an area of the brain that causes an impairment of consciousness. Okay? Um, and there are different places, but the most important places are the temporal lobe, which we just talked about, or the frontal lobe, because the frontal lobe has complex behaviors, right? It's our thinking area, executive function, planning, all this stuff. So if you have a focal seizure in the frontal lobe, it can definitely be complex because your ability to interact is going to be affected. Okay, does that make sense?
Yes. Can you also have motor responses with the complex?
Wonderful question. Absolutely yes. So it just depends if the complex components are sending signals to the motor cortex. In fact, I'm here. I'll mimic one. I did this for the students as well. I'm feeling it coming on. That's my aura. I can just kind of feel it building. It's coming. I'm gonna have it now. And that was a seizure. Okay. And you
Mm.
saw I was kind of having chewing movements of my
Hmm.
face. I had some sort of posturing of my hand, and that's because whatever was happening internally was sending signals to my motor strip to have these movements as well. Okay? So, two main types of focal seizures, simple, complex, but only occurring in one space. Now then, there's the other main category, which is generalized. And that's when basically the entire brain undergoes hyperexcitability and hypersynchronization. Now, I still remember when I was a medical student, which was quite a while ago, by the way. Um, I still remember learning about this and thinking, that doesn't, I mean, it's not like the whole brain all at once immediately goes into a seizure. That can't be. But it's close to that. It's basically, think about the entire brain is just ready to catch on fire, and all you need to do is throw in one match and boom, immediately the entire brain is going. And and this is actually the main cause of genetic epilepsies, where large population of neurons, both sides of the cerebrum, the brain, are just they have a lowered seizure threshold, and all it takes is just one area to start, and boom, it goes over both sides. And we have a number of different types. I'm not going to go into great detail here now, but you've heard about them. One type is called absence. This is a special type of epilepsy common in childhood that involves this circuit. These seizures are not as severe in that the children, usually, occasionally adults have this, have very brief interruptions of consciousness, but they don't fall to the ground. Um, they basically are just like almost like uh, they're out of it. They're zoning out for a couple of seconds. Fortunately, of the various types of seizures, this is one of the relatively more benign syndromes because many children with absence outgrow it, although not all. The most common one, which all of us are familiar with, is the tonic-clonic seizure. And that's where the entire brain starts firing abnormally, which means that all the muscles in the body are being contracted at once, usually, and that causes the tonic phase. And then as the brain begins to quiet down, you get these jerking movements because there's inhibition in addition to excitation, and that's the generalized tonic-clonic seizure. Okay? Then there are more rare, but some of you may be familiar with this. They're oftentimes in children who have the more severe forms of epilepsy with developmental delay. Atonic is actually a loss of tone, and these people, similar to generalized tonic-clonic seizures, fall to the ground and can be injured, of course. And then there's myoclonic or sudden brief jerks, which for our discussion is less important. But finally, I said that I'm emphasizing two types, but there's actually three. And the third one is exceedingly important. And that is that you can have a focal seizure that then generalizes. Okay? Really important conceptually. In fact, if there's one thing that I hope you walk away from today, is that you're going to really understand this. That a person can have a seizure focus. It can start the focal seizure, the kinds we've just been discussing. But if there's enough of a tendency for hyperexcitability, it can actually eventually spread to the entire brain and lead to a full-blown generalized seizure. Okay, so there's really three categories, and I highlight this for the students because I want them to know how important it is to know the difference between a generalized seizure and one that starts out with a focus. Okay, so um, let me do a quick pause here. I think time-wise I think we're in good shape. But I do want to check in. Does anyone have any questions about what I've covered so far? Because there's just a couple other things that I want to mention to sort of build on this. But my goal with all of you today is for you to gain the ability to have in your mind's eye what these different types of seizures actually represent. Does anyone have any questions at this point?
I have one, but you might end up going over it with the videos. So if someone's head is turned a certain direction, does that typically mean that it's starting in the opposite way that they're looking?
Wonderful question, and the answer is typically yes, that's right. If someone looks to the left, the seizure focus probably started on the right. That's a great question.
What if limbs are not symmetrical? So like
Also,
one is maybe up here and one's down here.
also depends, but if the onset is showing some, and I have a video of this, is showing some posturing or, stretching
Mhm.
out of one arm or a clonic movement of one arm at the beginning of the event, that's very good evidence that it's probably starting in a focus on the opposite side of the brain. And then eventually it can spread to both sides. But
Mhm.
asymmetry is oftentimes a clue.
Oh,
Any
thank
other
you.
questions that you see there, Casey?
Let's see here. Megan. Oh, we talked about the absence. Um, Megan, you talked about focal, temporal lobe, and GI. Were you wanting to know if maybe there was a correlation between those two?
GI,
Um,
go ahead.
Oh, good. Right
yeah,
on.
sorry. So Chloe has severe GI issues, and her doctor thinks that they're actually also abdominal seizures.
Oh, abdominal teeth. Well, I mean,
And I've
there.
seen some information, like some research that says that it starts in the temporal lobe.
Yes. Okay. Yes. So of course the seizures, even though the GI tract has neurons, they don't undergo seizure activity down there. But you're absolutely right. There are parts of the temporal lobe that have to do with uh, our sensation of what our gut is doing. And so, in fact, they're called gustatory seizures. So, yes, that is absolutely the case. That's an example of where our autonomic nervous system is always detecting the status of our GI tract, and we usually don't feel distress or pain because it's just kind of doing its thing unconsciously. But in the case of a seizure, it actually might um, activate those areas and cause someone to have symptoms. Yeah, that's a great question.
There's another question of why is it important to know if it's generalized or focal with secondary generalization? What
Oh,
useful information does that give us?
oh, that's just such a great question and
Good
unbelievably
question.
important. At least when I teach our medical students, it's one of the main things I want them to know. In someone with a focal seizure onset, whether it's focal and stays focal or focal with secondary generalization, what are we concerned about? We're concerned about a structural lesion in the brain causing the seizures. We're concerned about, could it be a tumor? Could it be an abscess? Could it be a stroke? Could it be some other traumatic brain injury? Could it be a malformation of cortical development? That our baby was born with a part of the brain that didn't go exactly in the right place, and that then creates a focus. So when we have people with focal seizures, we want to make sure that we have discovered whether or not there's an abnormality, a structural abnormality in the brain that might require surgery or some other kind of treatment, or an antibiotic for an abscess. On the other hand, with generalized seizures, um, they're 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 not coming from a single focus, but our concern is much more about a genetic cause or a metabolic cause, some kind of abnormality of, blood sodium or liver toxicity, or there are many, many different metabolic causes. So so it's both the diagnostic workup to understand what the basis is and the choices of medications, if required, are they can be different depending on whether it's focal or generalized. There are some medicines, I'm just going to pick out a couple. I don't want to go into the details of anti-seizure drugs today because it's a whole nother discussion. But there are some drugs like Depakote, I'll pick one, valproate, which is really only best used for generalized seizures overall, okay? And not particularly helpful. It can be, but less so with focal. On the other hand, again, I'm just picking one drug, carbamazepine, Tegretol, or oxcarbazepine. These drugs are definitely better in focal, and in fact, they oftentimes should not be used in generalized seizures or epilepsy because they can actually make the seizures worse. So, so both so both diagnostically and therapeutically, we want to know the difference between focal and generalized. And again, just a reminder, in our minds, focal and focal with secondary generalization are the same with regard to the concern about a focus, right?
Mm, okay.
Yep.
And then does it throw in a whole nother wrench with a diagnosis of SCNAA where you know that it's a genetic? So would there be times that maybe, for us, sodium channel blockers typically work well? Is that, are we going mainly off of seizure type at that point in time, or are we going off of genetics,
You're
or a
going off
little
of
both?
genetics. You're going off of genetics mostly because those are generalized seizures that we're witnessing typically, with the various sodium channel variants. And as you know, it depends on the particular mutation because some of them are what we call gain
Hmm.
of function and some of them are loss of function, and that can
Right.
actually influence which drug you're going to use because again, sometimes a drug like Tegretol will make things worse depending on the mutation. Yeah.
Gotcha.
Yeah.
One more question before we move into videos. If someone has an abnormal EEG, but there aren't seizures like actually noted, but this person has learning issues or difficulties, I guess what does the abnormal EEG versus seizures, just like the background waves?
Yeah, so it really depends, but I mean, if you're talking about abnormal but without evidence of electrical seizures with the EEG, that that gets into the many different types of abnormal EEGs that can be seen with children and adults with neurodevelopmental delay. And there are many, I'll just say NDD space. The NDD space is much, much bigger, well, much bigger than epilepsy. Epilepsy is, depending on the epilepsy type, can be within the overall population of NDDs. There are also plenty of people with epilepsy who do not have neurodevelopmental delay. So yes, the EEG can be abnormal in someone who has not had any seizures, don't have epilepsy, but they do have abnormalities of brain development.
Gotcha.
Casey, can
Mhm.
I add on to that? We're having a
Sure.
new neurologist next week. Finally, and like just any like points of direction in terms of care because she's been diagnosed with an intellectual disability.
Yeah,
Yeah.
yeah, unfortunately, I'm not going to be able to provide any sort of direction with regard to your medical care for anybody. I've talked with other groups like this, and frequently people do have questions about their specific, loved one, but without being directly involved in their care or being able to do a proper, additional opinion, I just don't want to even offer any kind of advice. I'm also not a child epileptologist, so I wouldn't even feel comfortable giving advice. I'm sorry. I wish I could help, but I can't.
No worries. One more question. So seizures that are happening very deep into the brain that sometimes the EEG cannot detect.
Ah.
Is there any way to detect those, and how common are seizures that EEGs cannot see?
Yeah, so again a very sophisticated question. So, when we do when you've had any EEGs done, we don't necessarily, or we can't plan on having the EEG done when our patient has a seizure, right?
Right.
The seizure might be occurring, once a month or 3 times a week, but it doesn't necessarily mean that the seizure is going to occur during that 1 hour of an EEG in the EEG lab. So frequently, most often, when we get an EEG, we do what's called an interictal EEG. Inter, between, ictal, seizure. That's another term for seizure. So an interictal EEG may still show abnormalities, even though the person's not having a seizure. But it's usually much more subtle. Like instead of the big waveforms that we saw in that one EEG, it might only be one spike that comes up, every couple of minutes. And that's just an indicator that there's an abnormal region of excitability in that area. So, so, I mean, that's basically the way that the EEG may or may not show abnormalities. Does that answer the question sufficiently?
I think so, but I'll keep an eye on the chat.
Okay. Um, all right. So I don't think we're going to get to the videos, but I have a little bit more here. This is important. And let me just make sure. Yeah. This is important because going back to what I was saying about the different seizure types, we've already kind of talked about this, that the frontal lobe, if the seizure is coming from the frontal lobe as a focus, then the person may have quite impaired functioning, right? Similar to the temporal lobe. And here's the motor, here's somatosensory. And as I said, these regions don't tend to be as uh, 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 susceptible to having a seizure. I also wanted to show you this very sort of funny and entertaining picture, and that's this. Um, this is called the homunculus. Homunculus. I think it's related to the Latin of like little person or something. But
Huh.
what this is showing, let's just look on the right side here. This whatever it is, kind of brownish purplish color, relates to the motor cortex, which I'm outlining with my arrow here. And it turns out that different parts of the motor cortex subserve different parts of our body. So our face is over here. Our arm and hand is around here. And our leg and feet is down in this part, in the central part of the brain. Can you see the arrow okay?
Mm-hmm.
Yeah. So, and notice how big the hand is and how big the face is, because it's got so much dexterity. It needs a lot more complicated innervation than, say, my shoulder. But the reason I wanted to bring this up is if we had a seizure focus that was down, way down here, not involving here, but there's like a little tumor or an abscess or some other abnormal thing that's causing a focus right down deep inside on the right hemisphere, what would be the seizure? Would it be focal or generalized?
I'm gonna say generalized.
No, well, I said
Shoot.
it's just happening here.
Oh, never mind. Sorry. Yes. So it would
It
be focal.
it's focal and it's only in the motor strip. Okay, so is it going to be simple or complex?
Simple.
You're right. There you go. It's simple because consciousness is not going to be altered. And where will the seizure occur? Like what will we see in the patient? Right-sided down in this interior here.
Um, would it be down in like the leg area?
Yes. Exactly. Right or left side?
You said it was on the right, so the left.
There you go. And that would be a focal simple seizure of just the leg. Very good. Very good. Okay. And then I think this is the last slide I'm going to show you because, again, we're just out of time. But this is one video of one of our patients, and I'm going to see if you can classify it. She's asleep right now, and the video's running. It's just that she's waking up.
Hey, you okay? It's all right. It's okay. It's okay, sweetie. Sorry,
Okay, I'm just going to stop it there because
Mm-hmm.
I still find it very hard to watch these videos. But what type of seizure do you think this was?
So her left leg started first, it looked like.
Okay.
Was that correct?
Yes. Well, she first awoke out of sleep.
Okay.
Uh, yeah. And I'll lead you on here. Do you think that her consciousness was normal or impaired? She woke up from sleep, but then what was her level of consciousness? Do you think that she was fully aware of
I didn't think
everything?
she was fully aware.
No, I agree. I agree. So there it and this did not look like a generalized tonic-clonic seizure,
Mm-mm.
right? And so we would say that this was probably focal.
Vocal complex.
Exactly. And given that type of behavior that she was having, we weren't surprised to learn that she had a focus in her frontal lobe, that
Mm-hmm.
executive function. And the frontal lobe was causing her to sort of act out whatever it was that her frontal lobe was abnormally creating in her brain. And so this was a focal complex seizure from the frontal lobe.
Okay.
Okay. So there you go. We just took a trip through seizure classification. But as I said at the beginning, my main goal when I'm with my patients, family members, is I really think it's useful for us to understand what's going on in the brain because as you all know better than I do because of your own lived experience, one of the one of the most challenging parts about living with epilepsy is the stigma associated with having this disease. And stigma is completely related to a lack of understanding. When we see someone who has broken their leg and they have a cast, there's no stigma associated with that because all of us know what happened. We can see, we know exactly what a broken bone is like. But because most people don't understand what the complex, what is going on, as historically and still in many parts of the world, there's only one reasonable explanation for the behavior of the patient that I just showed you on that last video. And that is she must be inhabited by demons because that's the only way that someone will behave that way. And of course, that's complete ignorance and a lack of understanding. So I hope I've been successful in helping you understand this and that you can spread the word, teach other people who are asking about what's happening to my child. Let them know that you understand. Okay?
Awesome. Thank you so much, Dr. Lowenstein. I really, really appreciate it. And before we wrap up, I just wanted to say really quickly, thank you so much to our sponsors. We have Praxis Precision Medicine and Neurocrine Biosciences that help us put on this education series each fall. And so we can get more education for our families. And so we can continue on with that awareness journey and help advocate for our kiddos. All right. Thank
All
you,
right.
everyone. Appreciate it. Bye,
Take
Dr.
care.
Lindsay.
Bye-bye.